about addiction. Since psychiatry's come a long way recently in changing certain things and describing addiction, ultimately you want to have biomarkers in psychiatry. You want to make all psychiatric diagnoses neuroscience based, including substance-related disorders. We have to make sure we're using correct terminology now. In America, with the new DSM-5, there's been several changes. Although when you do your billing for the visit, you use ICD-10 and you have to unlearn all the new changes. So let's go over the new changes. First of all, dependence. The term dependence is considered normal now. There's no abuse category. So when you hear people talk about substance abuse, that term is essentially outdated. You have to change your whole title of your treatment center or something. As we'll discuss, abuse and why it's no longer a category. We'll touch on moving gambling to the addictions group and consider other behavioral addictions like internet gaming disorder, sex addiction, food addiction. The latter two are no, but internet gaming disorder is popular. Caffeine use has been added, and the new fetal alcohol syndrome term that I've discussed before. The main thing, this is all in the chapter on substance use disorders in psychiatry. Now let's take a look at why is dependence no longer used. Remember in the old criteria in DSM-4 there was abuse, which included things like failure to fulfill major role obligations, hazardous use, substance-related legal problems, social, interpersonal, substance-related problems. That's abuse. Dependence is more tolerance, withdrawal, persistent desire with unsuccessful efforts to cut down, using more over a longer time than was intended, neglect of important activities, a great deal of time spent in substance activities, psychological and physical use-related problems. That was dependence. So for abuse, you had to have one of those four, and for dependence, 3 of those 7. So that's really hasn't been useful. That's part of the reason why there's been a lack of good treatment. So what should be done about abuse? Should abuse be combined with dependence to create a single disorder? Should new criteria be added, like craving? Or old criteria, like legal problems, be removed? Can nicotine criteria be aligned with other substances? Can cannabis and caffeine withdrawal be included? What should be the diagnostic threshold? How should severity be indicated? What about the international considerations? The confusion about the relationship of abuse to dependence exists because abuse is assumed to be milder than dependence. That's false thinking. This leads to thinking that abuse is a prodrome to dependence, or all cases of dependence met the criteria for abuse. And furthermore, reliability and validity of dependence is excellent. But the reliability and validity of abuse is much lower, much more variable than dependence. For example, 50%, looking at those criteria for abuse, 50% with abuse were diagnosed with only one criteria, the hazardous use. So, using different ways to analyze these terms and what to use, and looking at different patterns of use, abuse, and dependence reported. For example, current alcohol use and dependence, current cannabis use and dependence, current lifetime cocaine use and dependence. You'll see in dependence really is addiction. In DSM-3 in 1987, and DSM-4 in 1994, and now in DSM-5, dependence, that's addiction. When you talk about dependence, you mean addiction. For example, there's tolerance, withdrawal, use more than intended, unsuccessful use despite negatives. That's an addiction. The substance abuse criteria is supposed to be less. Maladaptive use within 12-month period of one or more of the following. Failure to fulfill major role obligations. Recurrent use in hazardous situations. Recurrent substance-related legal problems. Continued use despite consistent social or interpersonal problems. None of those met the criteria for dependence, though. So this criteria, this term dependence and addiction is the confusing terminology. Now let's move on. Let's try to explain it another way. You want to get rid of the term dependence and use addiction. So let's look at substance use can lead to abuse, which can lead to addiction. But substance use can lead to abuse and not lead to addiction. Or you can just have substance use and no abuse or addiction. So the relationship you want to look at is use, abuse, and addiction. Addiction is essentially increasing use with increasing severity. Whereas regular use is same use without increased severity. Now looking at substance use disorder, reframing it. You do not want to use the term abuse and dependence anymore. You have the 11 criteria, which are similar in most of the substances. Tolerance, however that's not counted if it's prescribed by a doctor. Withdrawal, same thing, that's not counted if prescribed by a physician. More use than intended, craving for the substance, unsuccessful efforts to cut down, spend more time in acquisition, activities given up, use despite negative effects, failure to fulfill major role obligation, recurrent use in hazardous situations, continued use despite consistent social or interpersonal problems. Those 11 criteria. Notice tolerance, withdrawal, the craving symptom, and the lack of the legal criteria. They got rid of that. Therefore, issues include no more abuse and dependence terms. You can't say opiate abuse, opiate dependence, alcohol abuse, alcohol dependence. You have to say opiate use or alcohol use disorder, and it's either mild, moderate, or severe. If you have up to 3 of those 11, it's mild. If you have up to 6, it's moderate. If you have all 11 or 7 to 11, it's severe. But what about patients who are on agonist maintenance with methadone or Suboxone? This requires moderate to severe opiate use disorder as the specifier, or included in the diagnosis. So you would say, if somebody's in the methadone clinic or taking buprenorphine, you have to have opiate use disorder, moderate or severe. Now, tolerance, therefore, is a normal reaction. Let's get away with that. You can be tolerant to opioids, benzos, but also antidepressants. What do you think the whole thing about the SSRI wearing off? And antihypertensive can cause tolerance as well. So tolerance is a normal reaction to medications. Now let's discuss cannabis withdrawal. This is another very important new finding in terminology. It's been recognized there's clearly cannabis withdrawal symptoms. But the point is it's finally recognized and separated from the hallucinogen type drugs, which could be hallucinogen of the PCP type or other. Cannabis has been moved more with caffeine, cannabis withdrawal, caffeine withdrawal. Cannabis withdrawal, irritability, anger or aggression, nervousness or anxiety, sleep difficulty, insomnia or disturbing dreams, decreased appetite or weight loss, restlessness, depressed mood, at least one of the following physical symptoms: stomach pain, shakiness, tremors, sweating, fever, chills, headache. So cannabis withdrawal is not something to be afraid of. As far as people saying there's no withdrawal from cannabis, there's no withdrawal from PCP or hallucinogens. So it's very good to separate cannabis from hallucinogens. Hallucinogens don't have withdrawals, but cannabis does. Therefore, that represents a significant advancement in psychiatry. And don't get upset about cannabis withdrawal. And there's going to be a lot of patients that need to be treated for that. So what? There's the same thing with alcohol withdrawal and caffeine withdrawal. Here's caffeine withdrawal, and we'll end. Daily use of caffeine, 3 or more of the following: headaches. This is after stopping. Marked fatigue or drowsiness. Dysphoric or depressed mood or irritability. Difficulty concentrating, symptoms of nausea, vomiting, muscle pain, or stiffness. Clinically significant distress or impairment in social, occupational, or other important areas of functioning, and not due to the direct physiologic effects of a general medical condition. Caffeine withdrawal. Caffeine use disorder has proposed criteria. We'll end there and do a separate video on gambling disorder and internet gaming disorder, proposed criteria. Please see the video on neurobehavioral disorder associated with prenatal alcohol exposure, which is also included in this whole substance use disorder category in psychiatry. To summarize, there's no immediate state or abuse dependence, only a single dimension. Mild, moderate, severe. Number two symptoms are diagnostic threshold for the combined disorder. Number three, dependence is only used for pharmacological dependence, which is not a disorder.